All right, so this is our first talk. We're starting out with the pancreas here. Now, I have this idea that there are three general ways you can ask a multiple choice question about a given pathology in radiology. You can have the what is it question. This is the most common type. I show you a picture of something. What is it? Here are your choices, 5 choices. Pick the one that it is. The next kind, which is the second most common way to write a question, is I assume that you know what it is, and now I'm going to ask you an association. Or it's a linked kind of question where you've already told me what it is, and now I'm asking you, what syndrome is this associated with? How often is this bilateral? Does this have more or less risk of malignancy, X, Y, Z, that kind of stuff. Associations. And then the third kind of question, which is the least common, but is a way you can do it, is the next step question. And this can be, what is the next best test? This can be, does this get biopsied, or what laboratory value would be elevated? Remember that this has been like this for boards forever. The people who write boards want to pretend they are real doctors. And real doctors know, like, management questions. Even though as a radiologist, you have very little role in management. It's really completely outside of your scope of practice to be in there dictating, what kind of management or this and that kind of therapy gets done directly. I mean, you can hint at it, and it's nice to know, but you're not a surgeon. You're not a family medicine doctor, thank God, because who wants to spend their life looking between diabetic people's feet? Not me, obviously. A clinic, yuck. Right? Like, so let's do the first case. So this is a what is it question. So I'm just going to ask you something. What is the brightest T1 organ in the body? No picture. Not going to show you a picture. If I showed you a picture, that would be obvious. And this is kind of stuff that you don't think about it necessarily when you're scrolling through there. But when somebody asks you, you're like, I didn't really think about that. Probably should know that. So the pancreas, this is a pancreas lecture, right? Pancreas is the brightest T1 organ in the body. Next case is a what is it case. So notice where we're at. So the first thing that I like to do basically anytime I get any case is to identify the sequence. And this used to be an oral board strategy as far as like it. This is an axial non-contrast CT through the level of the pancreas. And you had to like sort of start out your case by saying that. Well, it's still actually useful. Not because you're describing things, but the thought process going through that. Okay, this is a T1, or this is a T2, or this has contrast, or this doesn't, because you can see different things based on that. So I know this is a non-con, so I'm not looking for anything that's enhancing. Looking at the cut that it's through, and depending on what the cut is, you're targeted at certain things. So this is a cut that you could use to look at the pancreas. This is a cut that you could use to look at the liver. This is a cut that you could use to look at the kidneys. Now, given that there's no contrast, you are probably not, that almost automatically excludes the liver and probably the kidneys as well. And what we have is an obvious finding right here, which is complete fatty replacement of the pancreas. So when you see this, you're supposed to say what? You're supposed to say CF. CF is the most common cause of pancreatic insufficiency in children. What's the second most common cause? This one's less common, right? This one's a zebra. Shwachman-Diamond syndrome. I had a conversation with an old school guy one time, and he asked me this question. I was a resident at the time. What's the second most common cause of pancreatic insufficiency in children? Of course, and I was a maniac, so I knew that it was Shwachman-Diamond syndrome. And then he's like, "Ha! You're never supposed to mention that because You're not supposed to mention that on oral boards, because then once you say you know it, then they're going to have to ask you follow-up questions about it. Like, well, we don't take oral boards anymore, right? It's written boards. All you need to know is, what is it? One piece of trivia about it. Yeah, it can look like CF. And two, it's the second most common cause of pancreatic insufficiency. 3, they're dwarfs, at least have short stature. You don't know that. They don't ask that, right? They only ask those first 2 things, and that's all you need to know. That's understanding the gamesmanship. Yeah, you just need to know the buzzwords. It's just like step 1. Just need to know the buzzwords. It's still a multiple choice test. It's still medicine. That's the way that you can ask medicine. It's all multiple choice. It's still buzzwords. So, association time. Okay, so we've got a guy with CF, a girl with CF, and now we've got association time. So notice that instead of showing you an axial plane, I'm showing you a coronal plane. So I have a checklist for coronal abdominal stuff that I go through, and I'm going to go through it with you now. It goes bile duct, spleen, kidneys if you're showing them to me, and bowel. And because bowel obstructions are probably easier to show on a coronal, especially closed loop obstructions, relative to an axial or a sagittal. Now the cut's going to be different for the bile duct, right? They're not showing me the bile duct, so I know it's not a bile duct thing. They're not showing me the spleen, so I know it's not a spleen thing. This cut's more anterior. This is a bowel cut, so it's a bowel. I'm zeroed right in on the bowel. So you may have made the finding now, which is there is stool within the small bowel. It's not supposed to be like that, right? Call that fecalization of small bowel loop. It's associated with slow transit, which basically is saying it's associated with bowel obstruction. So in a setting of cystic fibrosis, when you're being told that the patient has a bowel obstruction, remember, these are kids, right? They're not getting bowel obstructions unless they've had some kind of prior surgery. This is a specific entity that CF patients get. DIOS, they call it, or distal intestinal obstruction syndrome. Basically, you've got thick bowel secretions result in obstruction. So who gets this? It is the result of poor compliance with their diet enzymes. You know, the pancreas does more than just make insulin, right? It also makes these digestive enzymes. So if you don't have those, you can end up having this kind of stuff happen to you. You can get it thickened secretions and end up with bowel obstruction. So why would they stop taking their enzymes? Classic scenario is they just got their lung transplant and they don't have CF anymore. They don't think they have CF anymore because they're teenagers and they don't understand CF. So they got new lungs, they're feeling a lot better. I don't need to take those pills anymore. I don't have CF anymore. So that's a classic scenario. It's actually described in the literature as being more common in that situation, and that's when you'll see it. So I'm going to roll through some congenital cases now. So this is the first one. So let's practice. We've got a T1 fat saturated MR, and then we've got a coronal, or plane of a small bowel or a upper GI, right? And so what can we see here? Well, we know we're dealing with the pancreas, but let's play the game real quick. You can see the kidneys, you can see vascular relationships, and you can see the pancreas. So those are the only things that are on the film. You're not going to get questions about stuff that's not on the film, only about stuff that's on the film. So what are some pathologies that exist with regard to the pancreas that can be seen on barium? So we said, okay, what were the things we can see here? Vessels, kidneys, pancreas. So we know it's not going to be a kidney case because it's an upper GI. There's no upper GI pathology that shows up that's a kidney thing. Vascular stuff outside of like SMA syndrome, but that's not what's going on. This person doesn't look like they've had rapid weight loss, obviously. So we know we're dealing with a pancreas thing. So when I see an upper GI, and I know it's a pancreas case, the first thing that comes to mind is an annular pancreas that is wrapping around the duodenum and causing constriction. And that's exactly what we're seeing here. And knowing that, look at it here. Now here's what gets tricky is that anytime that you read about annular pancreas in a book or you visualize it conceptually, it looks like this, right? This is the cartoon that they typically show, something like this, where it's in this coronal plane. Notice that for the CT or MR, I didn't show it to you in a coronal plane. I showed it to you in an axial plane because I was being sneaky. So instead, when you're looking at an axial plane, it looks like something like that, right? Like a donut with a hole in the middle, or so a piece of bowel is the hole. So that is the way that an annular pancreas is classically shown on imaging. Axial plane. So I'll repeat this throughout all the talks, especially in pediatric talks. Anytime you don't know what something is associated with and you're given choices, always pick Down syndrome, because Down syndrome is associated with tons of stuff. Anytime you're asked at the view box what something's associated with, we're talking about peds now, I would say Down syndrome, because it's common and it's associated with lots of different stuff. So in a kid, an annular pancreas results in a bowel obstruction, as opposed to adult, or an annular pancreas results in pancreatitis. Now, how do you keep that straight? The way that I keep it straight is by thinking if it was tight enough that it was going to cause an obstruction, it would cause an obstruction early on. That it's not going to suddenly become tighter just because you got older. And if you can keep that straight, then the other one is the other one, and you can just remember pancreatitis older on. So, yeah, if it's not formed correctly, there's a good chance that it's not going to drain correctly, and then you can get pancreatitis. Plus, an adult is more likely to stress the pancreas by drinking or having gallstones or whatever, something like that, that's going to cause pancreatitis. So here's a second congenital case. Again, what cut are we at? Contrasted axial CT. Through the level of the pancreas, we have one kidney, we got the liver. So it can be either this, that, or you could be looking at a vascular relationship. So we know we're doing pancreas cases, so we're cheating a little bit. And you may notice that the pancreas looks too short. Where'd the rest of it go? Where's all the pancreas over here? Now, it could be out of plane, right? But if you look down at your answer choices and you saw that dorsal agenesis of the pancreas was one of them, you can't really exclude that if you can't scroll up and down, right? So if they wanted you to exclude that, they would have given you the option to scroll up and down, or they would have shown you a coronal plane or some other plane where you can rule that out. Because you can't, that's what we're dealing with here. So dorsal agenesis of the pancreas is this, something like that. And so what's wrong with being short? You can still be successful if you're short. You just got to think big. So what's wrong with it is that you've got less of a pancreas, so maybe you can make a little bit less insulin. So it's associated with high blood sugars, associated with diabetes. Now, every time that I've seen it, the patients had polysplenia. And that is something that you can read about, but the number one thing that I would remember is that. All right, next congenital case. This is another gamesmanship one here, okay? So we've got, what level are we at? A little bit of liver, a little bit of one kidney, vessels, pancreas. Now, looks like we're missing the back half of the pancreas on this cut too, but I will tell you that when you looked at your choices, dorsal agenesis of the pancreas is not on there. What I'm trying to show here is this duct relationship. There's a duct here, and there's a duct here with this one running anterior. So this is a classic look, and it is a classic diagnosis. So let's take a look at what the normal pancreatic ductal anatomy is supposed to do. So typically, you've got your main pancreatic duct here, which drains through the duct of Warsong, that thing, and that empties, along with the common bile duct, into the major papilla. Now, you also have this smaller duct of Santorini, the minor duct. Santorini is small, Santorini is superior, and that drains into the minor papilla. So the big one into the major papilla, the minor one into the minor papilla. Santorini small. Now in divisum, you have failure of the dorsal and ventral pancreatic ducts to fuse. So instead of getting that sort of stair-stepped look, they are horizontally oriented, like you're climbing a ladder, and that's what you're seeing there on the CT. And the result of this is that the dorsal pancreatic duct, the big one, is draining into the minor papilla, the smaller one, and the ventral pancreatic duct is draining into the major papilla, so along with the common bile duct. Now, the consequence of that is if you have a night of heavy drinking or something like that, you stress your pancreas, this papilla can't empty this pancreatic duct fully, so you end up with pancreatitis. So just recapping here, the big duct will drain into the minor papilla. It's common, this is very common, like 15% of the time people have it, so you may have one, and it sets you up for pancreatitis. So, and lastly, for the purpose of gamesmanship, sure, they could show it on an MRCP, like coronal, that would be easy. Don't expect the underhanded softball throw. If they want to get sneaky, they're going to show it to you in an axial plane with MR or CT. All right, now let's do some cystic stuff. All right, we got a T2. When you see a T2 through the abdomen, you should think about cystic stuff first. If you're looking at the liver, you may be thinking about cystic stuff versus HCC, which can be that evil gray. It's like an off bright. So let's do some gamesmanship. What is the most important to ask yourself when you see this picture? This is like in your internal monologue. When you're alone in your chair by yourself and you're not allowed to talk, what should you ask yourself in your mind? You should say, why are you showing me this picture? Why are you torturing me like this? Why must you hurt me? So the reason is, I want you to think through this. It's a T2. Why? Maybe I'm trying to show you the duct. The duct is a thing you can see on T2, but I can sort of see the duct, but not really. Now, why would I care about that? Why would I care about the duct? Because ductal communication is going to make it so that you can differentiate between a lot of different stuff. So here's your duct. So you can differentiate between this and that. So things that are clearly communicating with the duct would be like a side branch IPMN, right? Things that aren't communicating with the duct would be the other stuff. If they don't show you the duct communicating with it, then it's not communicating with the duct. In the real world, you'd say, well, I'd scroll up and down because maybe it is communicating with the duct, just not if that's cut. No. For multiple choice, if it's not communicating with the duct on the slice they give you, then it's not communicating with the duct. If they wanted you to see it communicating with the duct, they would show you a cut where it communicates with the duct. So let's talk location. Is this helpful? It can be. This versus that, head versus tail. So the mucinous cystic neoplasms, they're almost always in the tail. And when you get a statistic like 80%, then it's always for multiple choice. The serous cystadenoma is more variable. You'll read sometimes it's in the head, but it can occur in the tail as well. It's less helpful. Some other trivia, the morphology, whether or not it's a bunch of little microcysts like this versus one unilocular cyst. Calcification patterns, where you've got sort of central calcifications versus peripheral calcifications. So serous cystadenoma is central, mucinous along the outside. Another trick is looking at the question header, biasing yourself with the history. They're not gonna lie to you with the history. Probably not. I would take anything that they give you in the history as a hint. So if they tell you that it's a 51-year-old female, or they tell you that it's a 75-year-old female, or they tell you it's a 16-year-old Asian female, notice that I did not give you ethnicity on these other ones, but now suddenly I'm mentioning that they're Asian. Oh, that's funny. Why are you suddenly saying the word Asian? Hint, it's a hint. Or if I tell you that it's a guy that's got all these risk factors for pancreatitis, right? So let's do them. Let's do a practice one here. So it doesn't matter, like with these kinds of histories, it doesn't matter what the image is showing you if you can't figure it out from there. They could show you a picture of shoes, okay? You should be able to get these right. So the 51-year-old female, that's a mother. That's the mother lesion, M for mother, okay? 75-year-old female, that's a grandmother. You know, Grandma Serious is the head of the household. Asian females are spens, right? Those are more solid and cystic. And then somebody who's had pancreatitis has got pseudocysts. So let's sort of review these again. We'll go through all the little, it's like a summary slide. So pancreatic mucinous cyst neoplasms, mucinous. There is not a ductal communication. It is the mother lesion, M for mucinous, M for mother. The calcification pattern is peripheral. And they are commonly in the tail, and they're bad. They're bad guys. They are precancerous. Mucin's always bad, right? Serous this also has no ductal communication. It's your grandma tumor. She's serious. There are central calcifications, not peripheral calcifications. The location is more variable. It can be in the head. It can also be in the tail. It's less helpful. It's helpful for the mom. Mom just sits on her tail. And these are benign, but they can grow slowly over time. A pseudocyst also has no ductal communication. They're going to tell you the patient's had a history of pancreatitis. And by the revised Atlanta criteria, you need 4 weeks before you can call it a pseudocyst. Side branch IPMNs, they're going to show you the duct communication. If they don't show you the duct communication, there is no duct communication. Duct communication. And they're more common in men. All right. So if I show you a serous cystadenoma, or a cyst in the pancreas, or an islet cell tumor in the pancreas, you should think about von Hippel-Lindau. And von Hippel-Lindau has a whole bunch of different stuff, and it's got PHIOs, it's got renal stuff, and it's got CNS stuff, and a whole bunch of other things. And I have a way to try to organize your brain to remember these things. So von Hippel-Lindau is 3 letters. Von Hippel-Lindau, 3 letters, 3 categories. So category 1 is the pancreas. All right, so everything that can happen in the pancreas basically does increased in von Hippel-Lindau. So serous cysts, more cysts, and islet cell tumors, which are these hyper-enhancing guys. And then there's other stuff in the belly, mainly centered around the kidney. So cysts, renal cell carcinomas, clear cells, bilateral at an earlier age, and pheochromocytoma. And then in the head, we're talking about hemangioblastomas in the posterior fossa, this thing, cystic nodule, hemangioblastomas in the spine, this guy right here, and the endolymph sac tumor, okay, which is located at the vestibular aqueduct, which is where your endolymph sac is. And I'm going to talk about these more in the you will get this repeatedly. I will hit this in the neuro lecture. I will hit this in the renal lecture. So it's coming back multiple times. Now here's a trick. It's a mousetrap. Von Hippel-Lindau has an association with another cyst in another location, and that's the epididymis. Okay, so you read 60% of males have them, bilateral. So anytime you get a statistic that's high like that you're reading about, that's like an always for multiple choice. If it's 60, 70, 80% of the time, just think about that in your head as that always occurs with this entity for the purpose of multiple choice. let's do a companion case. All right, so what am I showing here? So I'm at the cut of the pancreas, kidney, liver, little thing there, meaningless. Not going to show little stuff like that on multiple choice. Pancreas is looking funny. Duct looks dilated, sort of right there, right? So here's an MR, T2. T2 is good for looking at the duct. Are they showing you the duct? Yeah, they're showing you the duct. So the duct is dilated. There's no obvious reason for obstruction. Would be nice if they showed you gallstone or something like that. They're not showing you the common bile duct. They're not showing you double duct sign. So this is a main branch IPMN. So I mentioned these side branch IPMNs. This is the main branch IPMN. So dilated duct, no cause of obstruction. This is basically treated like cancer. It's high risk. So if you were asked, which one's worse, side branch or main branch IPMN? Main branch is way worse. Way, way worse. Side branch IPMNs are the pulmonary nodules of the pancreas. You see them all the time. Most of the time they don't mean anything, just like pulmonary nodules in the lungs. Sometimes they're cancer. They're usually nothing. You still got to follow them. All right, more cystic stuff. What about this thing? So this is obvious, right? Pancreatitis, the big cyst, right? Pseudocyst. So what's the most important factor for outcome or survival in the setting of pancreatitis? So pick one thing. One thing you're going to see on the image that's going to tell you this patient's going to have a bad outcome or they're going to have a normal outcome, a good outcome. Going to be out of the hospital in a couple of days. Necrosis. Necrosis is bad. So there's this kind of chart breakdown. You can read about this in books. So no necrosis, the mortality is very, very low. Once they have necrosis, then their mortality goes way up, and then you go into categories if it's infected or not infected. So if it's not infected, and you don't want to be sticking tubes and stuff in it, although you'll probably be asked to, but if you get a necrotic or necrotizing pancreatitis that gets infected, your mortality is super high. You are deader than fucking fried chicken, if you've got pancreatic necrosis and you're infected. So what do you call these things? Do they have names? Oh, everything's a pseudocyst. Every fluid collection beside a pancreas is a pseudocyst. Wrong. Well, I mean, probably just fine, actually. But, radiologists like to do what? They like to argue about vocabulary and obsessive vocabulary. Like, everybody knows the guy that's like the word Nazi and obsessive. Don't these things that you're saying mean the same thing? No. Don't say that. Say this. So there are set vocabulary words. There are rules. There's this thing called the revised Atlanta criteria. They, a bunch of radiologists, GI people, whatever, get together and what vocabulary words are we going to use? So first thing is necrosis or not necrosis. And then you got time intervals, 4 weeks, less than 4 weeks. It's an acute, because it's less than 4, peripancreatic fluid collection. More than 4 weeks, then you can call it a pseudocyst. Okay, just think about that it takes 4 weeks to get a rim around it, and then it's like a cyst. Before that, it's just fluid. Necrosis, less than 4 weeks. Acute, again, the word acute is listed there, so it's less than 4. Both of the times when it's less than 4, it's got the word acute in it, okay? More than 4, walled off necrosis. So just like a pseudocyst is sort of walled off as a rim around it, walled off necrosis in the setting of necrosis. All right, so moving down. Tension. So I have a checklist that I do when I have a pancreatitis case. A couple of things that I look for. I look for enhancement. That's the number one thing. The next thing I look for fluid collections, and then I look for vascular stuff. So what are the vascular stigmata of pancreatitis? Portal vein thrombosis, splenic vein thrombosis, splenic artery pseudoaneurysm, GDA pseudoaneurysm. That's my 4 things that I look for. So let's go. So portal vein, thrombus. So in the setting of pancreatitis, if you're seeing a case, remember I was pointing out, like, what can we see? And I always mention the vessels. Vessels. Look at those vessels as a consequence. All right? So there you go. All right, so there's my checklist for vascular stuff. All right, next case. So we're talking about pancreatitis. Got a kind of a funny looking pancreas here, T2, T1 pre, T1 post. Might say that thing looks like a sausage, right? Sausage shape, low attenuation halo, absence of pancreatic duct or biliary ductal dilatation. So all these things should make you think autoimmune pancreatitis, right? You should not be thinking, pancreatic ductal adenocarcinoma or anything like that. So let's do the trivia here. Pancreatic duct. Is it, now we're talking about autoimmune pancreatitis here. Fat or skinny? Fat or skinny? Fat or skinny? Skinny? Or fat? Which one? So fat pancreatic ducts, think cancer. Skinny pancreatic ducts, think autoimmune pancreatitis. All right. What about edema? Inflammation? Yes or no? So, seeing a bunch of inflammation, think regular pancreatitis. Not seeing any inflammation, autoimmune pancreatitis. All right, so what are some associations with autoimmune pancreatitis? So I say autoimmune pancreatitis, you say IgG4 related sclerosing disease. Specifically, you want to see retroperitoneal fibrosis, mediastinal fibrosis. You want to see these weird looking things all over the kidneys, right? These guys. All right, so these are the tubular interstitial nephritis. That's your kidney stuff. Supposedly, it's immune complex deposition, sclerosing cholangitis, Riedel's thyroiditis, anything that's sclerosing or fibrosing or anything like that you think about with autoimmune pancreatitis. All right, so that's the end of this first talk, and our second talk will be a continuation, dealing more with solid pancreatic pathologies and some other random stuff.